So a lot of patients ask, well, what exactly are you doing in surgery for postherpetic neuralgia? Now, if you've already come to see me and we've talked about surgery, we've gone over this in a lot of detail, but I'm happy to go over it again now. And then for those of you that are watching this video who haven't yet had that conversation with me, this will hopefully be very helpful and a fruitful discussion for you. So the classic teaching with postherpetic neuralgia is that there is a virus. It's called the herpes zoster virus. Okay, it's the virus that's responsible for not just shingles but for chickenpox. Okay, you've probably heard that before if you have postherpetic neuralgia. You've probably read that online. You've probably seen it at a bunch of different forums and support groups. Right now, the classic teaching is that the virus lives in a part of the nerve which is right next to the spinal cord. Okay. And that treatment of the pain has to do with treating the part of the nerve where the virus lives. Okay, and that was the prevailing theory and what I believed for a very long time until a number of years ago I ran across a patient who came to me because I had operated on a friend of his. And he said, "Doc, I know you helped my friend with his pain. Can you help me with mine? Can you help me with my postherpetic neuralgia?" I said, "Sir, your friend had a very different problem than the one that you do. I don't know how to help somebody with postherpetic neuralgia." This is what I told him. And he said, "Well, Doc, you got to do something." And he was crying and begging me. And finally I said, "Look, the kind of surgery that I would do, potentially, theoretically, would be what's called a neurectomy, where we disconnect the nerve. We effectively turn that nerve off surgically, right? I can simulate the results of surgery with an injection. I can temporarily turn that nerve off with an injection. Just like when you go to the dentist. The dentist numbs up your mouth. He's temporarily turning off the nerve in your mouth so that you don't feel any pain while the dentist is doing dental work, right? So we can do something similar. And I can do that injection for you to prove to you that surgery isn't an option, if that's what it takes for you to believe what I'm trying to help you understand. And he said, "Please, I'll do anything." And so I did the local anesthetic injection. I did the nerve block to shut off this nerve. And he started to cry. And I, in my mind, I thought, "See, I told you." And I said, "Sir, what's going on?" And he said, "This is the first time in years that I haven't had this pain." And of course, I was really skeptical. I didn't believe it. I said, "No, that's got to be a placebo effect." So what I want you to do is go home, take some notes over the next few days on how you're doing. Okay, from hour to hour if you need to. And then come back and see me in a few weeks and let's see how you're doing, right? So he comes back and sees me a few weeks later and he said, "Doc, I felt amazing for a few hours after the surgery." And then the pain all came back and it hasn't gotten any better since then. And I said, "Okay, well, I'm pretty sure that's a placebo effect. I'm pretty sure that wasn't actually a result of the nerve block. It's just a placebo effect. And the way I'm going to prove that to you is by repeating the injection today, because it's highly doubtful that you would have the placebo effect exactly the same way twice in a row." He said, "Okay." So I did the injection. And sure enough, he started to cry again. And again, I thought, well, yeah, it didn't work this time. And he said, "Doc, same result as last time. The pain is gone." And I was really kind of taken aback. I was very surprised by this. And he said, "So when are we going to do surgery?" And I said, "Well, I don't know if that's such a good idea." And he said, "Look, you told me that the injection temporarily turns off the nerve, right?" I said, "Yes." And he said, "And you told me that it would be a good preview or a good simulation of what surgery would do, because surgery permanently turns off that nerve, right?" I said, "Yes." "So why don't you just do permanently what these injections have done temporarily?" I said, "Sir, I'm not convinced that this is actually going to help you." And he said, "Please, even if it doesn't work, at least I know we tried. At least we gave it a shot. At least there's a chance." I said, "Okay, fine." So we went to the operating room a few weeks later, and we had the exact same conversation again before surgery. And he said, let's just do it. I said, okay. And so we went and we did the surgery, right? And he woke up pain-free. And he's been pain-free ever since. And that was, I think, about 8 years ago. And so I thought to myself, wow, that's really surprising. So a few weeks later, he sends me a friend of his, same problem, postherpetic neuralgia. And I told her the same thing I told him the first time around. I said, I don't know that there's anything I can do to help. She said, well, you helped my friend so-and-so. Just do the same thing for me. I said, well, it's more complicated than that. Well, let's do the injection. So we did the injection. Her pain went away. She came back a few weeks later. We did the injection again. Her pain went away. So we did the surgery, and her pain is now gone. And that was at the point at which I realized, you know what, maybe there is something to this. And so I started doing a little bit more digging through the medical literature and all the different research articles. And there are a few medical research articles which suggest that with postherpetic neuralgia, the problem isn't actually in the nerve root where the virus lives. The problem may actually be arising as a result of the scarring that happens where the skin and the nerve come together, which is a very different location than where the virus lives. And that if you can disconnect that scar tissue and the pain signal that it's sending from the rest of the nervous system, then the pain signal doesn't ever get to the brain and the patient doesn't experience pain anymore. And so that's what we've been doing for the last 8 years. Basically, we just disconnect that nerve. We take out a segment of the nerve, or nerves if there's more than one involved, so that the pain signal from the scar tissue doesn't get to the brain. Okay? Part of the reason I take out a segment of the nerve is to decrease the likelihood that the nerve is going to reconnect and cause chronic pain again. I also take that nerve, and depending on which part of the body it is, I'll either implant it into the surrounding bone or implant it into the surrounding muscle, or I may actually graft a piece of skin or muscle onto it so that the nerve has something to do and doesn't cause pain in the future. Okay? The success rate with that is pretty high. Again, depending on which part of the body it is, as much as 95% of our patients will have significant or complete relief of their symptoms a year after surgery. And so, does this guarantee that patients won't need further surgery in the future? No. In some patients, they will need more than one operation. And in some of those patients, we don't know they'll need more than one operation when we do the first operation. As much as possible, I try to identify in advance which patients will need more than one operation. So as an example, if somebody comes in and they've got postherpetic neuralgia on their chest that starts in the back and wraps around to the front, I expect that that patient's going to need at least 2, maybe 3 separate operations in order to treat their postherpetic neuralgia. Okay? If somebody comes in with postherpetic neuralgia of the arm, I expect that that patient's going to need at least 2, maybe 3 or more operations in order to pin down all of those nerves. Because again, the anatomy is variable, and sometimes it has to do with positioning. We can't get to all the nerves in one operation. In other cases, it's hard to identify, is it 1 nerve, 2 nerves, 5 nerves that are involved, and so we have to take it in a stepwise fashion and chip away at it as we can identify those nerves. I know that that can be really frustrating sometimes for patients, but as much as possible, I try to let patients know in advance whether or not I expect there to be 1 or more operations.